Okay, now we're going to begin on myopathies and pain syndrome. The first syndrome we're going to talk about is idiopathic inflammation and myopathies. So there's a classification of either polymyositis that does not involve the skin or dermatomyositis, and this is associated with a characteristic skin rash. Okay, so what are some of the causes of idiopathic inflammatory myopathies? So we have the hypothesis, and it's a genetically susceptible individual plus environmental triggers that leads to immune activation, which results in chronic inflammation. There is pathological changes in the muscles. In dermatomyositis, you're going to see humoral immune mechanisms, and in polymyositis and inclusion body myositis, you're going to have cell-mediated processes. What are some of the clinical features of idiopathic inflammatory myopathies? The features common to both polymyositis and dermatomyositis include symmetrical proximal muscle weakness that develops subacutely over weeks or several months. The earliest and most severely affected muscle groups are the neck flexors, shoulder girdle, and pelvic girdle muscles. Distal extremity weakness is less frequent and typically less severe. There is myalgia in 33% of patients, dysphagia in up to 30% of patients, and involvement of striated muscle in the upper GI tract. It is more common in female patients. It has associated findings that include congestive heart failure, conduction defects, arthralgias, and interstitial lung disease. Some of the features that are unique to dermatomyositis include a heliotrope rash, which may also be described as a butterfly rash around the eyes, bridge of the nose, and cheeks. You're going to have Gothorn papules, which are papular erythematous scaly lesions over the knuckles of the MCP, PIP, and DIP, which may also be called mechanic gloved hands. You're going to have V sign, which is rash on the face, neck, and anterior chest. Shawl sign, which is rash on the shoulders and upper back, elbows and knees. You're going to have periungual erythema with telangiectasias. Subcutaneous calcifications in children can be extremely painful. It is associated with vasculitis of the GI tract, kidneys, lungs, and eyes. This is more common in children. There is an increased incidence of malignancy in older adults, such as breast, lung, ovary, GI tract, and myeloproliferative disorders. Once dermatomyositis is diagnosed, make an effort to uncover an occult malignancy. Dermatomyositis associated with malignancy often remits once the tumor is removed. To diagnose an idiopathic inflammatory myopathy, you're going to want to run some lab studies. These are going to include the CK level, and it's going to be significantly elevated. CK levels correspond to the degree of muscle necrosis, so one can monitor the severity of the disease. You're also going to have LDH, aldolate, AST, and ALT elevated. There is going to be an ANA association in over 50% of the patients. You're also going to have anti-synthetase antibodies, also called anti-Jo1 antibodies. These cause an abrupt onset of fever, cracked hands, Raynaud phenomenon, interstitial lung disease, and fibrosis, and arthritis. This does not respond well to therapy. You can also have anti-signal recognition particle, which can have cardiac manifestations that are common. It is the worst prognosis of all the subsets. You can also have, as another laboratory finding, anti-MI2 antibodies, which has better prognosis. Another laboratory study you can do is an EMG, and this is abnormal in about 90% of patients. And finally, you can do a muscle biopsy, which will show inflammation and muscle fibrosis in all three. In dermatomyositis, you're going to have perivascular perimucosal inflammation. In polymyositis and inclusion body myositis, there's going to be endomucosal inflammation. The treatment includes corticosteroids as the initial treatment, immunosuppressive agents for patients who do not respond to steroids, such as methotrexate, cyclophosphamide, and chlorambucil, and physical therapy. Okay, and so the diagnostic criteria for polymyositis includes includes symmetric proximal muscle weakness, elevation in serum creatinine phosphokinase, EMG findings of myopathy, biopsy evidence of myositis, and a characteristic rash of dermatomyositis. If two of the first four, you have possible polymyositis. And if you have three of the first four, you have probable polymyositis. And if you have all four, you have definite polymyositis. Okay, now we're going to move on to inclusion body myositis. This is more common in men that are elderly. Has an insidious onset of slowly progressive proximal and distal muscle weakness, which often leads to delay in diagnosis. There's early weakness and atrophy of the quadriceps, forearm flexors, and tibialis anterior muscles. Involvement is asymmetrical. Facial weakness occurs in 1/3 of patients and dysphagia in about 1/2 of patients. Patients can also have a loss of deep tendon reflexes. Nerves are not involved in polymyositis and dermatomyositis. You're going to have extra muscular manifestations that are rare. Diagnosis includes a slight elevation of CK levels, which are relatively low. You're going to have poor response to therapy, and it is not associated with any autoantibodies. Inclusion body myositis is the oddball of the inflammatory myopathies for the following reasons. It affects male patients more than female patients. There's absence of autoantibodies, and it's the distal muscle involvement and relatively low creatine kinase levels, and has a prognosis that is poor. Okay, now we're moving on to polymyalgia rheumatica. This usually occurs in elderly patients. It is rare before the age of 50. The mean age of onset is 70 years old, and it is more common in women. The cause is unknown, but an autoimmune process may be responsible. There is a possible genetic link with an association of HLA-DR4 allele. It is a self-limited disease and lasts about 1 to 2 years. Some of the clinical features include hip and shoulder muscle pain, which will be bilateral. It often begins abruptly, but may be gradual. There's going to be stiffness in the shoulders and hip regions after a period of inactivity and the most prominent symptoms. Pain occurs on movement. The muscle strength is normal. There's going to be profound morning stiffness that is common. There's going to be some constitutional symptoms. These are going to be malaise, fever, depression, weight loss, and fatigue. You're also going to have joint swelling, and up to 20% of patients have synovitis in the knees, wrist, or hand joints, and can be confused with rheumatoid arthritis. Synovitis and tenosynovitis around the shoulder may lead to a rotator cuff tendonitis or adhesive capsulitis. Signs and symptoms of temporal arthritis, if present. To diagnose polymyalgia rheumatica, it is essentially going to be a clinical diagnosis. You're also going to have ESR that is elevated, which aids in the diagnosis, but it's almost always greater than 50, but frequently can be greater than 100. This correlates with the disease activity. To treat polymyalgia rheumatica, you're going to give corticosteroids. The response is usually within 1 to 7 days. Corticosteroids are not curative, but are effective in suppressing inflammation until the disease resolves itself. After 4 to 6 weeks, begin to taper slowly. Most patients, 60 to 70%, can stop corticosteroids within 2 years. A few patients have symptoms for up to 10 years. And about 10% of the people with polymyalgia rheumatica would develop temporal arthritis, whereas up to 40 to 50% of people with temporal arthritis have coexisting polymyalgia rheumatica. Okay, now we're moving on to fibromyalgia. Adult women account for 80 to 90% of the cases. It is characterized by chronic non-progressive course with waxing and waning in severity. Many patients improve with time. The key to diagnosis is there's going to be multiple trigger points that are tender to palpations. It is going to be symmetrical. There's 18 characteristic locations that have been identified, including the occiput, neck, shoulder, ribs, elbows, buttocks, and the knees. The etiology is unknown. Somatization is not a proven cause. Okay, so some of the clinical features of fibromyalgia include stiffness, body aches that are musculoskeletal, fatigue. Pain is constant and aching and is aggravated by weather changes, stress, sleep deprivation, and cold temperature. It is worse in the morning Rest, warmth, and mild exercise improve the pain. Sleep patterns are disrupted and sleep is unrefreshing. Anxiety and depression are common. How do you diagnose fibromyalgia? So the diagnostic criteria includes widespread pain, including axial pain for at least 3 months, pain in at least 11 of the 18 possible tender point sites. There are no specific confirmatory tests for fibromyalgia, therefore it is important to rule out or consider the following conditions: myofascial syndromes, rheumatoid disease, polymyalgia rheumatica, ankylosing spondylitis, spondyloarthropy, chronic fatigue syndrome, Lyme disease, hypothyroidism, polymyositis, depression and somatization disorder, and hypertrophic osteoarthropy. So the treatment of and management of fibromyalgia includes to advise the patient to stay active and engage in low-intensity exercise. The first-line treatment for fibromyalgia is amitriptyline. Some local anesthetic at trigger points is used acutely. Melniciprine, SNRI, and pregabalin are also used. Cognitive behavioral therapy should be considered with a psychiatric evaluation. Okay, so now that we're done with that section, we're going to move on to seronegative spondyloarthropathies. And the first one we're going to be talking about is ankylosing spondylitis. Ankylosing spondylitis has a strong association with HLA-B27, and this appears in about 90% of patients. However, the presence of HLA-B27 should not be considered diagnostic. It is 3 times more common in males than in female patients. Bilateral sacroiliitis is a prerequisite for making a diagnosis. The onset is in adolescence or young adulthood. It is characterized by fusion of the spine in an ascending manner from the lumbar to cervical spine. The course of ankylosing spondylitis happens as there is a slow progression, but the course is highly variable. There's going to be acute exacerbations that are common. Life expectancy is usually normal. The first 10 years of the disease can give an indication of the long-term severity. So some of the clinical features of ankylosing spondylitis include low back pain and stiffness secondary to sacroiliitis, which limits motion in the lumbar spine, neck pain and limited motion in the cervical spine. This occurs later in the course of the disease. Enthesitis, which is inflammation at tendinous insertions into bone, such as the Achilles tendon and supraspinatus tendon. With extensive spinal involvement, the spine becomes brittle and is prone to fractures with minimal trauma. Severe spinal cord injury can occur with such trauma. There's going to be chest pain and diminished chest expansion. Due to thoracic spine involvement, there's going to be shoulder and hip pain. Most commonly, the peripheral joints are affected. There's going to be constitutional symptoms, which include fatigue, low-grade fever, and weight loss. There's going to be extra-articular manifestations, such as eye involvement, which is the most common. It includes acute anterior uveitis or iridocyclitis. Other extra-articular features are rare, but may involve the following systems: the cardiac, which includes AV, heart block, and aortic insufficiency, the renal system, pulmonary, and nervous systems. There's going to be loss of lumbar lordosis that can occur as the disease advances, leading to inability to stand upright. When severe and symptomatic, this may require spine reconstruction. In order to diagnose ankylosing spondylitis, you're going to want to do some imaging studies of the lumbar spine and pelvis, such as a plain film X-ray, MRI, or CT, which will reveal sacroiliitis, sclerotic changes in the sacroiliac area. Eventually, the vertebral columns fuse, producing a bamboo spine. You're also going to have elevated ESR in about 75% of patients due to inflammation, and this is not specific. HLA-B27 is not necessary for diagnosis, but is present in about 8% of the population. In order to treat ankylosing spondylitis, you're going to give NSAIDs such as indomethacin for symptomatic relief, anti-TNF medications such as etanercept and infliximab. You're going to want to do physical therapy, maintaining good posture, and extension exercises. And surgery may be necessary in some patients with severe spinal deformity. Patients with ankylosing spondylitis who sustain even minor trauma and who complain of neck or back pain should be strictly immobilized to prevent spinal cord injury until thorough imaging studies are obtained. In ankylosing spondylitis, low back pain and stiffness are characteristically worse in the morning and better as the day progresses. They improve with activity and hot showers and worsen with rest and inactivity. Complications of ankylosing spondylitis include restrictive lung disease, cauda equina syndrome, spine fracture with spinal cord injury, osteoporosis, and spondylolisthesis. Okay, so now we're going to move on to reactive arthritis or Reiter syndrome. Some of the general characteristics of reactive arthritis are asymmetric inflammatory oligoarthritis of the lower extremities. And the upper extremities are the less common. The arthritis is preceded by an infection process that is remote from the site of arthritis, usually 1 to 4 weeks prior, and it's usually after an enteric or urogenital infection. It occurs mostly in HLA-B27 positive individuals. Reiter syndrome is an example of reactive arthritis, but most patients do not have the classic findings of Reiter syndrome, arthritis, uveitis, and urethritis. So the term reactive arthritis is now used. The organisms usually associated with the reactive arthritis include Salmonella, Shigella, Campylobacter, Chlamydia, and Yersinia. What are some of the clinical features of reactive arthritis? So you're gonna want to look for evidence of infection, such as the GI or genital urinary tract. 1 to 4 weeks before the onset of symptoms, you're gonna look for asymmetric arthritis. New joints may be involved sequentially over the days. Joints are painful with effusions and lack of mobility. There's going to be fatigue, malaise, weight loss, and fever that are common. Joint pain may persist or recur a long-term period. To diagnose reactive arthritis, you're going to send synovial fluid for analysis to rule out infection or crystals. There is no test specific to reactive arthritis. To treat reactive arthritis, you're going to give NSAIDs as a first-line therapy. If there is no response, then try sulfasalazine and immunosuppressive agents such as azathioprine. Antibiotics used is controversial and is usually not given. Reactive arthritis is a clinical diagnosis. If any patient has acute asymmetric arthritis that progresses sequentially from one joint to another, reactive arthritis should be in the differential diagnosis. The term undifferentiated spondyloarthropy is used when a patient has features of reactive arthritis, but there is no evidence of previous infection, and the classic findings of Reiter syndrome are absent. Okay, so now we're done with reactive arthritis. We're going to move on to psoriatic arthritis, and this develops in greater than 10% of patients with psoriasis. It is typically gradual in onset. Patients usually have skin disease for months to years before arthritis develops. It is usually asymmetric and polyarticular. You're going to have characteristic sausage digits and nail pitting that may also be present. The upper extremities are most often involved, and the smaller joints are more common than the large joints. Initial treatment is NSAID, but persistent arthritis may require methotrexate or anti-TNF agents. Steroids are typically not used. Okay, so now we're going to move on to vasculitis. The first one we're going to talk about is temporal or giant cell arthritis. This is a vasculitis of unknown cause. It is typically in patients of greater than 50 years of age. It is twice as common in women as in men. The temporal arteries are most frequently affected, but it may involve other arteries such as the aorta or carotid bruits, decreased pulses in the arms, and aortic regurgitation may also be observed. It is associated with increased risk of aortic aneurysm and aortic dissection. Some of the clinical features of temporal or giant cell arthritis include constitutional symptoms of malaise, fatigue, weight loss, and low-grade fever. You're going to have headaches that may be severe. You're also going to have visual impairment in about 25 to 50% of patients. This is caused by involvement of the ophthalmic artery. You're going to have optic neuritis, Maurice's Foucault, that may lead to blindness to up to 50% of the patient if it's not treated early and aggressively. You're going to have jaw pain with chewing, intermittent constriction of the jaw and tongue when chewing. There will be tenderness over the temporal artery and an absent temporal pulse. You're going to have palpable nodules. 40% of patients also have polymyalgia or rheumatica. To diagnose temporal arthritis, you're going to have elevated ESR, but normal ESR does not exclude temporal arthritis as the diagnosis. Biopsy of the temporal artery has a sensitivity of 90%. A single negative biopsy does not include this diagnosis. In order to treat temporal arthritis, use high-dose steroids such as prednisone early to prevent blindness. Start treatment immediately. Even if temporal arthritis is only suspected, do not wait for biopsy results. If visual loss is present, admit the patient to the hospital for IV steroids. Otherwise, start oral prednisone. If the diagnosis is confirmed, continue treatment for at least 4 weeks, then taper gradually, but maintain steroid therapy for up to 2 to 3 years. Relapse is likely to occur if steroids are stopped prematurely. Follow up on ESR levels to monitor the effectiveness of the treatment. Visual loss in one eye may be temporary or permanent. Prompt and aggressive. Steroid treatment is primarily given to prevent involvement of the other eye, but it may improve the outcome on the affected eye as well. Even if untreated, the disease is eventually self-limiting in most patients, although vision loss may be permanent. Keys to diagnosing temporal arthritis: age of greater than 50, a new headache, tenderness and palpation of the temporal artery, high ESR, and jaw claudication. If temporal arthritis is suspected, begin prednisone and order a temporal artery biopsy. Okay, so now we're going to talk about some vasculitis. In all vasculitic syndromes, blood vessels are inflamed and vascular necrosis can result. Findings depends on the size of vessels involved and the location of involvement, such as target organ ischemia. If any patient has systemic illness that has not been explained by any process or has ischemia involving one or more organs, entertain the diagnosis of vasculitis. It is classified according to the size of the vessels. For large vessels, you're going to have Takayasu arthritis and temporal arthritis. In medium vessel arthritis, you're going to have PAN, Kawasaki disease, which is a pediatric disease, Wegener granulomatosis, Church-Strauss syndrome, and microscopic polyangiitis. For small vessel, you're going to have Henoch-Schulden purpura, hypersensitivity vasculitis, and Behçet syndrome. Now we're going to move on to Takayasu arthritis. Takayasu arthritis is most common in young Asian women. It is a granulomatosis vasculitis of the aortic arch and its major branches, leading to fibrosis and potentially causing stenosis or narrowing of the vessels. It is diagnosed via arteriogram. Some of the clinical features for Takayasu arthritis include the constitutional symptoms of fever, night sweats, malaise, arthralgias, and fatigue. Pain and tenderness. You're going to have pain and tenderness over the involved vessels. There's going to be absent pulses in carotid, radial, or ulnar arteries. Aortic regurgitation may be present. Signs and symptoms of ischemia eventually develop in areas supplied by the involved vessels. There's going to be severe complications, which include limb ischemia, aortic aneurysm, aortic regurgitation, stroke, and secondary hypertension due to renal artery stenosis. The main prognostic predictor is the presence or absence of these complications. It can also cause visual disturbances due to ocular involvement and hemorrhage of the retinal arteries. To treat Takayasu arthritis, you're going to want to give steroids such as prednisone that may relieve the symptoms. Treat the hypertension, and surgery or angioplasty may be required to recannulate stenosed vessels, and bypass grafting is sometimes necessary. Takayasu arthritis should be suspected in a young woman with decreased or absent peripheral pulses, discrepancy of blood pressure in the arms versus the legs, and arterial braze. Okay, so that is it for Takayasu arthritis. Now we're going to move on to Church-Strauss syndrome. This is a vasculitis involving many organ systems such as the respiratory, cardiac, GI, skin, renal, and it can also be neurologic. Clinical features include constitutional findings of fever, fatigue, and weight loss. There's going to be prominent respiratory tract findings such as asthma and dyspnea. You're going to have skin lesions such as subcutaneous nodules, papillopuria, as well as eosinophilia. Diagnosis is made by biopsy of the lung or skin tissue. There's going to be prominence of eosinophils. It is associated with P. onca. The prognosis is poor with a 5-year survival rate of 25%. Death is usually due to cardiac or pulmonary complications. With treatment with steroids, the 5-year prognosis improves to 50%. Okay, so now we're going to talk about Wegener granulomatosis. This is a vasculitis
that predominantly involves the kidneys and upper and lower respiratory tracts, and sometimes other organs as well. The clinical features of Wegener granulomatosis include upper respiratory symptoms such as sinusitis. This is purulent or bloody nasal discharge, oral ulcers that may be painful, pulmonary symptoms such as cough, hemoptysis, and dyspnea. You're going to have renal involvement. This includes glomerulonephritis that may have rapidly progressive renal failure, some eye disease such as conjunctivitis and scleritis, musculoskeletal involvement such as arthralgias and myalgias. You're going to have tracheal stenosis, and you're going to have constitutional findings of fever, malaise, and weight loss. To diagnose Wegener granulomatosis, you're going to want a chest radiograph that's going to be abnormal with nodules or infiltrates. The laboratory findings include markedly elevated ESR, anemia, which is going to be normochromic, normocytic, hematuria, positive C-onc in about 90% of patients, which is sensitive and specific, and thrombocytopenia that may be present. You're going to want to do an open lung biopsy to confirm diagnosis. So the prognosis is poor, and most patients die within 1 year after the diagnosis. A combination of cyclophosphamide and corticosteroids can induce remission in many patients, but a relapse may occur at any time. Consider renal transplant if the patient has end-stage renal disease. Most patients with Wegener granulomatosis also have sinus disease, pulmonary disease, and glomerulonephritis. Renal disease accounts for the majority of the deaths. Okay, now we're moving on to polyarthritis nodosa, or PAN. This is a vasculitis of medium-sized vessels involving the nervous system and GI tract. It can be associated with hepatitis B, HIV, and drug reactions. The pathophysiology of polyarthritis nodosa is a PMN and polymorphonuclear cell invasion of all layers and fibrinoid necrosis plus resulting in intimal proliferation that leads to a reduced luminal area, which results in ischemia, infarction, and aneurysms. There is necrosis and there is segmented necrosis leading to a rosary sign as a result of aneurysms. Some of the clinical findings of PAN include early symptoms that are fever, weakness, weight loss, myalgia, and arthralgias, and abdominal pain, i.e. bowel angina. Other findings are hypertension, mononeuritic multiplex, and libido reticularis. Diagnosis of PAN is made by biopsy of the involved tissue or mesenteric angiogram. ESR is usually elevated and P-onc may be present. You're going to want to test for fecal occult blood. The prognosis is poor, but is improved to a limited extent with treatment, and start corticosteroids immediately if PAN is severe, and add cyclophosphamide. There is no pulmonary involvement in PAN, which distinguishes it from Wegener granulomatosis. Okay, now we're moving on to Behçet syndrome. This is an autoimmune multisystemic vasculitic disease with unknown origin. The clinical features include painful, sterile, oral, and genital ulcerations. This is called pathergy. Arthritis of the knees and ankles is most common. There's going to be eye involvement, which include uveitis, optic neuritis, iritis, and conjunctivitis. There's also CNS involvement, which include meningoencephalitis, intracranial hypertension. There's also going to be fever and weight loss. Diagnosis is made by biopsy of the involved tissue. Laboratory tests are not helpful. Treatment is steroids, which are helpful and often present to Middle Easterners. Okay, now we're moving on to Buerger disease, or thromboangiitis of the laterals. This occurs mostly in young men who smoke cigarettes. There's going to be acute segmental inflammation of small and medium-sized arteries and veins affecting the arms and the legs. And there's going to be inflammation in the veins that leads to superficial nodular phlebitis. It may also lead to gangrene and auto amputation. Some of the clinical features include ischemic claudication, cold cyanotic, painful distal extremities, paresthesia of the distal extremities, and ulcerations of the digits. You're going to have Raynaud phenomenon that may be observed as well. Smoking cessation is mandatory to reduce progression of the disease. The last thing we're going to cover is hypersensitivity vasculitis. This is a small vessel vasculitis that is a hypersensitivity reaction in response to a drug such as penicillin or a sulfa drug. It may also
come about from an infection or another stimulus. The skin is predominantly involved. There's going to be palpable purpura, macules, or vesicles that are common in the lower extremities. And these lesions can be painful. There's going to be constitutional symptoms, i.e. fever, weight loss, and fatigue that may be present. The diagnosis is made by biopsy of the tissue. The prognosis is very good, and spontaneous remissions are common. Withdrawal of the offending agent and steroids are the treatment of choice. Okay, so that is it for Chapter 6.